Hello, everyone. Welcome to our WTF series. This segment is called You Are the Ortho, Mastering InBrace Treatment Mechanics. So I'm Dr. John Pham. I'm one of the founders here at InBrace, and I'm joined here by two very special people, Dr. Andre Weissheimer and Dr. Hongsheng Tong, who have been with us on this journey since the very beginning. They were key drivers in developing and inventing the InBrace technology, and also key players in helping us start this company. So today's very, very special for me. So they'll be sharing a few cases with us today. And this is a webinar format. So, by all means, if you have any questions, please use the chat function and I will answer them, or I'll have Dr. Tong and Dr. Andre answer them. But also we'll try to keep the pace going too. This is meant to be interactive if you have any questions. We're going to follow up this webinar with a study club that's July 26th at 5 p.m. Pacific, 8 p.m. Eastern. That's going to cover many of the same topics you saw today, just more in depth. And that's going to be more of a sort of a Zoom format where we're all going to be on cameras talking, interactively than this webinar type format. So with that being said, I'm handing the stage over to Dr. Weissheimer.
Thank you, Dr. Pham. Welcome, everyone. So it's a pleasure being sharing this presentation with my dear friend, Dr. Hongsheng Tong, who is the InBrace inventor, along with Dr. Pham. Dr. Tong has taught me a lot. I learn every day from Dr. Tong, and then I'm sure you all will enjoy what he has to share today. Okay, so let's get started. So for this presentation, our learning objectives are demonstrating the InBrace treating mechanics. So you can use that to increase the predictability of your cases. We're going to show cases step by step, showing how to apply these treating mechanics, and sharing some tips and tricks and clinical pearls so you can improve the overall patient experience. Okay, so like everything in life, we have a learning experience, have a learning curve, right? So it happens to us as well. So we invest time learning, developing, creating these mechanics, creating the technology. So, and the purpose of that, using all these technologies to share all this information, so we can minimize the learning curve for our providers. So you can start already on the top of the game, right? Learning from our mistakes or our learnings, or all the clinical trials that we have been done, a lot of data that we have been collecting, troubleshooting, educational videos, validation protocols. We are sharing this so we can minimize the learning curve, and then you start your cases being way more predictable and efficient. Okay, so the summary of treatment mechanics, right, is in this slide where you can see the treatment sequence. So we call program non-sliding mechanics the way that we move it with InBrace, and basically there are some stages. So stage 1, stage 2, and then we do what we call digital enhancement. What is stage 1? Stage 1 is when we start. It's pretty much is level and aligning, right? It's our first SmartWire 1. Okay. So then we go to stage 2, where we're using SmartWire 2 and 3. Both have increased the rigidity. So we're going to express more tip and torque. Doing stage 2 is our working phase, is where we're going to apply inter-arch mechanics. And after that, when you need to reset the case, we take a tooth print, which we call intraoral scan, which we call tooth print, and then we redesign the case. It's called digital enhancement phase. Very simple. Stage 1, stage 2, digital enhancement. Okay, so there are some goals for each stage that we need to remember, and then we're going to be reinforcing this during the presentation, because this is a roadmap that can apply to all type of cases: simple cases, moderate cases, complex cases. So in stage 1, again, is to level and align SmartWire 1, very flexible, very resilient, easy to engage, right? So the goals for stage 1 is to have all the brackets in the planned bracket position. What I mean with that? sometimes we don't have all the brackets in the perfect position. We need to reposition some brackets, and is indicated in the treatment instructions. So once you have all the brackets already in the planned bracket position, so when we perform any IPR that is prescribed, and when you let this smartwire 1 express for a certain amount of time, usually 6, 8, 10, 12 weeks, so then we have all these requirements to go to the next phase, which we call stage 2. So stage 2, now we have smartwire 2 and 3. Both are more rigid. It's going to deliver more force to express more tip and torque and expansion or leveling curve speed, okay? So this is the working phase. Stage 2, we're going to use intermechanic elastics, we're going to use distalization, we're going to use TEDs, whatever. So it's when we do the heavy mechanics. So smartwire 2 and 3, at this point, we start decreasing the biturbos. So, and then we can continue treatment. So every time that you use heavy mechanics elastics, we can have some side effects. So the way to address some side effects of the mechanics, and even to capture bracket position inaccuracies during the direct body procedure during stage 1, they're going to be addressed during the digital enhancement. It's pretty much going to reset the case and have digital enhancement smart wires. Pretty much this is the sequence that we are always going to be reinforcing and can be applied in every single case, okay? So let's start seeing some clinical cases. So this is an adult patient, is a retreatment case. He had braces when he was a teenager, so now he's an adult. He doesn't want to show any visible braces. He doesn't want to rely on compliance of aligners. So it's a perfect case to be treated with InBrace modality, right? So what we have here, we have very good occlusion, posterior occlusion, class 1. We have his chief concern is crowding, is lower crowding and upper crowding. So it's a case that doesn't have a lot of things to do. So patients that have this type of malocclusions, they're more demanding because there's just a few things to improve. We need to treat in a short treatment time. And then we need to make sure that we're not going to create side effects or disturb this very good occlusion. So personally, I treat a case like this as I'm treating a difficult case, right? Because we don't want to things go south over here. So how we treat this case, right? Diagnosis. What is the skeletal pattern? Skeletal pattern class 1, horizontal skeletal pattern over here, horizontal vertical pattern over here, upper and lower incisors in a good position. So our goal is to keep upper and lower incisors in this proper position, okay? So Smile design, our digital setup. So what do we plan in this Smile design? So as you can see, you have midline discrepancy. This patient has a decreased upper incisor display. So we'd like to extrude a little bit the upper incisors and intrude the lower incisor if possible, improve midlines, level a line, avoid incisor proclination. At the same time, do not disturb the posterior occlusion, keep things in a good occlusion. So as you can see, level a line, upper and lower arches. Okay, there's IPR design in the lower arch, more on the right side to help with the midline correction. Okay, so then you're going to receive the case. You're going to have the treatment instructions. Treatment instructions is very important because this is our roadmap, what needs to be done in this case. So as you can see over here, there's some IPR designed for this case, more IPR on the lower incisor and more on the right side to allow the midline correction. Also, as you can see in red, upper right 3 is in this red color. It means that there's going to be bracket collision, right? After we do the fitting appointment. It means that we might need to use biturbo, okay? So this is our roadmap is going to prepare for the fitting appointment. So the bonding appointment, which we call fitting appointment, right, at InBrace. So usually we recommend 1 arch at the time, okay? So we've been learning over these years, and the reason for 1 arch at the time is because it's easy to integrate in a very busy practice, it's easy for the staff, and most importantly, it is a better patient experience, right? So nowadays we recommend 2 short fitting procedures, one for the upper, one for the lower, depending on the case, start with the lower. This case was on the early generation 2 case. We start with upper and lower feeding at the same time. So engage smart wire 1, upper and lower, and perform the IPR that was prescribed in the lower arch, okay? So it's very common in the beginning. So then we engage the smart wire, and then what comes next? What I'm gonna do the next appointment. In the beginning, we might feel lost, it's normal. I feel like that in the beginning, but here is what you're always gonna refer to, is the treatment sequence. So let's see stage 1 again, right? So all the brackets are in the right place, yes. The IPR was performed, yes. Smart wire expression, okay, the smart wire is gonna be working for 6, 8, 10 weeks until the next appointment, right? So likely stage 1 is gonna be completed because we have all the requirements. So likely for the next appointment, we expect to engage in smart wire 2, okay? Okay, so everything's ready. Patient go home, come back in 8 weeks, okay? So as you can see, upper alignment has improving pretty well, lower alignment has improving pretty well. Things are going super well. No breakage, no anything going south, everything looking great over here. So now, because we have all the stage 1 requirements completed, we can engage smart wire 2 in upper or in lower arches, okay? So we engage upper and smart wire 2 in both arches. And we are talking about mechanics here, but we need to remember that the beauty of this customized treatment is that the bonding procedure, the feeding procedure is 100% delegable to the staff. The wire changing, the smart wire changing is completely delegable as well, right? So that's why we're not mentioning this, but just to bring, because we're talking about the mechanics, but the delegation is always super, super important for this treatment modality. So here, staff engage upper and lower smart wire 2, and now we're gonna let this smart wire express. We call this phase the autopilot, right? So we need to let this smart wire to express. Okay, what comes next? What are we gonna do the next appointment? Should I change the wire or not, right? So again, let's check the treatment sequence. Okay, we just engaged smart wire 2. This smart wire 2 is gonna complete level aligning, is gonna continue expressing tip and torque, right? So, and then I would be ready to start inter-arch mechanics. So likely next appointment, we can start some rubber bands if needed, okay? So patient come back 8 weeks later. So as you can see, is still smart wire 2 upper and lower, don't need to do any smart wire changing, okay? Everything is working 24/7, don't rely on compliance wearing aligners, is working 24/7. That's why it's very, very efficient. At this appointment, we place some clear buttons to start intermaxillary elastics. So for example, to improve the midline, the lower midline was deviated to the left. We're using anterior diagonal elastics, lower left 3, upper right 3, and vertical elastics, upper right 3, lower right 3, to extrude upper right 3 a little bit, right? So these buttons are actually, they are a clear lower incisor bracket, 3M bracket, that we just break in half and use as 2 buttons. We learned this from Dr. Harry Doherty. Okay, very, very static. So we know that we are applying all these intermaxillary elastics, and after that, what comes next, right? So I'm gonna check the case, and likely it's gonna be digital enhancement, just to improve minor detailing and even address minor things that we might have because of the intermaxillary elastics, and address any remaining patient chief concern. So in this case, we submit for digital enhancement, and in digital enhancement, less is more. Especially in the beginning, we see people that tend to change too much the occlusion here, over there. So we try this minimalistic approach. So for example, in this case, so we need to extrude upper right 3 and then move upper right 3, give a inset, right? A step in adjustment. Also, notice that the upper right 2 over there, there's a mesial out rotation. We're gonna design a mesial in rotation. And here there's something that we learn over the years. Every time that you have this type of rotations, is gonna increase or decrease the interbracted distance, and is gonna activate the interproximal loop, the IP loop, the intelligent loop, to open or close space. So in this specific case, by moving the mesial in, we're gonna increase the interbracted distance. So it means that we are programming a space opening over there. So we can request the Smile Designer to increase the virtual power chain between upper right 2 and upper right 1. And usually we inform the patient, hey, we might have a small space between upper right 2 and upper right 1 is a temporary space, and usually it closes itself. And then we tell the patient up front, okay? It's very helpful because the patient comes back and says, hey, doctor, yeah, you're right. There's a little space over there. And then it builds credibility. Lower Smile Design, as you can see, minor adjustments. We do not change the posterior, just step in for both lower trees and add some minor detailing, okay? So 6 months progress, engaged the smart wire to upper and lower arches, okay? And then final 18 months, he's ready to debond, right? So we maintain the posterior occlusion, we improve the upper and lower alignment, which was the patient main concern, improve his smile arc, right? So panoramic, everything looks good over here. Ceph before and after, upper and lower incisors pretty much in the same position. Ceph, as you can see, it seems that the lower incisors were intruded. However, the patient opened the mouth a little bit during the final ceph. So, but pretty much it tells us that upper and lower incisors, they keep the original inclination, which was the goal for this case, okay? Every time that you do something, we look back and then what could have been done differently. In this case, as I mentioned, we reinforce one arch bonding or one arch feeding appointment would be better to improve patient experience. And then this is something that I always think about, but make things simple, right? Accept minor inter-arch discrepancy. Likely, this case could be the bond at 4 or 5 months in treatment. The patient was already happy. And then sometimes we as orthodontists, we try to improve 0.5 millimeters of midline. Maybe I would accept that because it extended the treatment 3 or 4 months. That might not be necessary, right? Less is more, okay? Thinking about efficiency and predictability. Yes, John.
Yeah, there's a question here regarding the case you just showed. If there's already a virtual power chain on the whole arch program, do I still need to ask for additional power chain between those teeth that you mentioned to not open the space?
Yes. So good question. So as a standard, right, as a default, InBrace is going to add 0.2 millimeters in every contact point as a default. However, you are the orthodontist, right? You're the master. Every time that you see like a specific movement, like a rotation that you might think that's going to open a space, especially on the anterior region, right? I would recommend you to request this additional. I don't check for the posterior, right? If you open a little bit space on the posterior, the patients will not complain. But I would say at least for the upper anteriors, double check. If you have rotations, maybe add a little bit of overcorrection. So InBrace overall is developing a system that our Smile Design is gonna add this information so that you don't have to think about it. But always is good to know that it might happen, and then request, especially in this transitioning, I would recommend you for the upper incisors to identify and request this additional power chain when you can see the interbracket distance increase, okay? All right, so let's see a second case. So this is a more difficult case, especially because the oral health condition. As you can see here, we have a maxillary cant, we have a dental cant in the maxillary arch, right? So the upper left segment has extruded over the years. We have this dental crossbite. So there's a lot of calculus in the lower arch. The lower teeth, they are inclined towards the lingual. Narrow upper arch and lower arches, class 3 tendons. And the challenge here is the tongue. The patient has a large tongue, which was very difficult to take the intraoral scan, the tooth print, how we call it, InBrace. So staff, skeletal class 1, horizontal vertical pattern, upper and lower incisors in a good position. Okay. So here's the Smile Design. So again, reinforce. You're gonna see this in the mini residence when you reinforce all the time. The digital setup or Smile Design, how we call it, InBrace. This Smile Design, we should see this as a force system, right? So we're not gonna design an ideal setup, especially in a case like this. So I always see the Smile Design as a force system. In this case, we are creating a force system to not only achieve an ideal, but overcorrect in over-intruding the upper left segment, okay? So you're gonna see molars in a class 3 tendency on the left side, on the right side, and then on the left side. And this smile design is over-intruding the upper left segment. So we are over-engineering, we're adding extra force to intrude. Lower arch, no IPR was designed, just level align, slightly expand the upper arch and upper right the lower arch in the alveolar bone, okay? This is the smile design. And then this doesn't mean that you're gonna get what you design over here. It's just a force system. So I don't expect the smart wires, they're gonna just correct the cant by themselves. I know that I need to use auxiliaries and then I need to plan for that. In this case, we're gonna use TEDs to support the intrusion in the upper left segment, okay? All right, treatment instructions for this case, as you can see, there's no IPR prescribed for this case. So you can see in red, there's bracket collisions on the upper left segment. So it means that we need to be ready for biturbos. Likely in this case, flexible biturbos to prevent the lower teeth to break the smart wire or debone the upper brackets, okay? So here's the challenge. As you can see, the patient has this super large tongue, macroglossia. The floor of the mouth raised and covers all the lingual surface, right? So this is one of the early Gen 2 cases, and then we had concerns. Hey, how's going to be this bonding? It was hard to take a tooth print. How's going to be this to do the feeding? The bond is going to stay. And we designed this case 7-7, right? So we're going to test how Gen 2 is going to perform in this case, and then how to be the comfort. If InBrace can work well in this case, it's going to work well in every case, okay? Okay, feeding appointment. So again, right, reinforcing. We nowadays recommend one arch at a time. In this case, I would recommend you to do just the lower arch to start, okay? Easy to delegate, easy to integrate, best patient experience. In this case, was an early case, we did both arches and we did 7-7, right? So as you can see, the lower arch, we can barely see the 7s, right? So the floor of the mouth is covering the 6 and it's covering the 7. So, but everything looks good. We fit lower and upper arch, and then you're gonna see that there's a biturb over there to prevent the bracket collision and smart wire breakage. So engage in smart wire 1, both upper and lower arch, biturbs are in place, no IPR is designed. So what comes next? Hey, Dr. Weissheimer, I don't remember what comes next. So let's check again. Stage 1 goes, start level aligning, okay? So brackets are in the proper bracket position? Yes, I don't need to reposition any bracket for this case, that's perfect. Is there any IPR designed? No, so we're good. Smart wire expression, we're gonna schedule this patient in 8 weeks, okay? So then the smart wire 1 would be likely finishing the expression. So likely, the next appointment, we can switch to smart wire 2, okay? And this is exactly what happened. Look how the alignment improved in the lower arch. Look how the alignment improved in the upper arch, okay? So no bonding failures, no breakage at all, everything going super well. From the comfort standpoint, it was a little bit difficult for 2 weeks for the patient. After that, he adjusts very well, okay? So the concern about comfort was eliminated, and concerns about bonding, especially because we have the 7s in a almost under the tongue, was good as well. So now, smart wire 2, upper and lower, engaged. So what comes next? So now it's time to turn on the autopilot. We don't need to do anything. Let's let these wires express. So again, so we are in stage 2. The goal for stage 2 is to complete intra-arch level and aligning, right? Finishing minor things, expressing more tip, more torque, right? In this specific case, because we need a more robust mechanics to intrude, we need more force for the cant correction, we're gonna go smart wire 2 and then on the sequence smart wire 3. Okay, next appointment, likely gonna have smart wire 3. Patient come back, 6 months in treatment. As you can see, the cant has improved significantly. So it's time to move to smart wire 3. Why smart wire 3? It's more rigid, it's gonna deliver more force. We don't use smart 3 often in the majority of the cases. It's gonna full control the movements. There's always minimal play, 2 degrees of play between the wire and the brackets, but it's less easier to engage than Smart Wire 2. That's why we just use Smart Wire 3 when it's really, really needed. And this is one of the cases, okay? And why is that? Because we're gonna intrude the upper left segment, we need more transverse control, right? We need more torque control as well. So let's see what happens later, right? So likely, next appointment is going to be digital enhancement because we're completing the cant correction, and we might have some side effects that we need to address. Okay, digital enhancement, we take a tooth print of this patient, and then this is what we designed for this case. Extrude upper right 3, okay? Add more labial crown torque for the lower incisors and improve minor detailing, okay? Okay, so when we have the wires back, we'll have Smart Wire digital enhancement, Smart Wire 2, and then when the staff is going to delegate, is going to engage this wire. Sometimes, hey, we cannot engage Smart Wire. Why is not working, right? So it's always good to know the reason here. So if for some reason we're struggling, engage Smart Wire, stop and observe. Never force hard. It's just about observation. So you observe, you're going to see that the leg of the locket was bent, right, during the engaging procedure. So if you know that this may happen, it's very easy to address this issue. We just use your winger to go over there and just slightly open the 2 little legs, okay? One more time. Go with your winger and slightly open. Doing this, you're going to easily be able to engage the wire. Again, the beauty of orthodontics, is going to hear this all the time. You can always do the same, different things to address the same problem. Dr. Tong has a very nice tip where he used the leg against the bracket. You slightly open that leg and be able to engage. There's another way to do that. Okay, so then we adjust this locked leg, engage the Smart Wire 2, digital enhancement Smart Wire 2, and let this Smart Wire 2 express, right? Let's turn on the autopilot. So patient moved to East Coast, couldn't come to West Coast all the time. So we are using digital monitoring. Here we're using green scope. Patient was wearing class 3 elastics, especially on the left side to improve the midline. So during this time, we were doing virtual monitoring until the patient could come back months later to get the case debonded. So again, the case at 14 months treatment when it was debonded. So again, it's a compromising treatment, okay? So it's not to get it perfect, but it's just to improve in the shortest time as possible and make in a convenient way for the patient. Patient is living on the East Coast, right? Digital monitoring. So here, a good posterior occlusion, improve alignment, improving the arch shape, not perfect, but much better than we started. Panoramic, showing everything looks good. Ceph, showing pretty much the upper incisors, we maintain the upper incisor position. The lower incisors, we slightly decrease the inclination, as you can see here in the Ceph, likely because the class 3 elastics, okay? So here's treatment comparison. So again, cases under 12 months, this case took 40 months, under 12 months of treatment is not to get it perfect, but it's to improve adult patient, is a realistic treatment. The cant was corrected, better smile, better oral health, better occlusion relationship, chief concern addressed, okay? We always learn from all these cases. If you ask us what we could have done differently, again, one arch fitting to improve patient experience would be easier. Looking back to the case, we would add like lower 3 overcorrection for intrusion and especially for labial crown torque. And especially for lower left 3, where we are applying the class 3 mechanics, we would add more mesial crown tape, okay? So again, to minimize the learning curve, our team has been working behind the scenes to create all these materials. Dr. Robert Lee and his team is doing an amazing job organizing all these ideas in a more digestible and easy to access information. So here you're gonna see the InBrace Smart design with all the information, how much overcorrection for vertical AP, transverse, arch length, right? So some guidelines and this InBrace toolkit for different type of malocclusions for class 2, open bite, deep bite, pace treatment, that if you don't remember how to do, you can check all the InBrace nuances about smart design on these guides, right? With that being said, I'm gonna hand it over to the master, the legend, Dr. Hongsheng Tong, to continue the webinar. Dr. Tong, it's yours.
All right. Good morning, everyone. Thank you, Dr. Weissheimer and Dr. John Pham for the introduction. That's really flattering. I appreciate that. And in the last, I would say, almost 10 years, I have the honor and the pleasure of working with Dr. Andre. And I would have to say that, his understanding of orthodontics, his, artistry, his attention to detail is really second to none. I have learned, so much, from working together with him. We spent a lot of, great time. I hope there will be more years that can work together. Okay, so I'm gonna dive into these cases. I know everybody, needs to see patients, so I'm gonna, try to keep it on pace. So it's gonna go pretty fast, and hopefully, in the study club, we can discuss more. Okay, so this is the first case. The patient is a 30-year-old female. The chief complaint is, the front teeth are open. And she looked into the Invisalign before, but then, she decides that's just not for her. She couldn't be disciplined enough, to wear Invisaligns. So she came to us, trying to get this resolved. As you can see, about 1.5 millimeter open bite, right side class 1, left side class 3, and the midline a little bit off to the right side. There's some spaces on the top, and there's some rotation crowding on the bottom. Nothing major. Okay. See. Okay, from the Ceph is basically skeletal class 1. There's some protrusion of both upper and lower incisors. Okay, the panoramic is you can see some moderate periodontal bone loss. There's some root resorption, probably from all these years of tongue thruster, in the front, jiggling those teeth. Okay, the next one is showing the smile design. The objective is to close the bite, of course, and get the teeth to fit right, obtain proper overbite and overjet. Let me see, get the video going. Class 1, both sides, as you can see, there's some spaces. The lower, few rotations, and on the upper, there's some spaces to close. So basically, we want to actually take advantage of the spaces and close the teeth back in, and using the relative extrusion, during the retraction of the teeth to help us close the bite. The upper already spaces, so the lower, we're going to add some spaces by doing the IPR. This is the patient-specific treatment instruction we get from the InBrace kit. And please, take good use of this. Don't just throw it away. As you can see from the instruction, the lower right 1 and the lower left 5 are not included in the indirect bonding tray. So be prepared to bond these directly, and don't get caught, by surprise at the chair side in front of the patient. Get that ready before you go in. Start the fitting appointment. There's no expected, collision. There's no bracket need to be repositioned. That's great. There's some IPR, as I said, in the lower, so remember to do that. At the fitting appointment, in this case, we fit both upper and lower arch at the same time, as Dr. Andre, mentioned earlier. Nowadays we'll probably just do, the lower. It's better for patient scheduling. Better for patient, experience, and also the staff would like that. You've got to do, what the staff likes. The upper, there's no problem. The lower left 5, as you can see, it is the bracket was bonded directly. Okay, and this is some skill. I'm sure orthodontists, after you do a few times, you can develop, and it's really important. Once you're good at that, it will help you a long way. the lower right one, I figured this, even if I can bond the bracket here, the bracket would be too close because of the rotation to the lower right 2 bracket, and it would be hard to engage the wire. So, I have a 80% effort rule. Okay, what is that? The InBrace is supposed to be easy. So if it's hard, then, I would rather not do it, because by forcing it, sometimes you would end up breaking things, So at this appointment for this patient, we just did the wire direct bonding, to this tooth. Next. So in just 2 months, what you see is here, the bite has pretty much closed. Okay, and the patient was really thrilled because this is in a long time, the first time that she told us that she can cut noodles, and she was really thrilled, and not a small achievement for her, actually good for her. And you can see actually the class 3 on the left side also resolved, and the midline is getting closer. How did that happen? It's probably resolving a functional shift. Maybe I'm just a little bit lucky in here. And as the saying goes, they'd rather be lucky than be right. And if you're lucky, then just go ahead and take it. I want to bring to your attention to the lower left 5. As you can see here, the rotation is fully corrected, in just 2 months. What happens is there's a little spacing here. I think Dr. Andre just mentioned, earlier that, when you are addressing the derotation, that's what happens. It comes from that push coil effect from the IP loop between the lower left 5 and 6. So temporarily here you got a space, but don't freak out. This is going to close, even though I did not add additional virtual partition effect in here, but the design is to keep, to have the space closed. So eventually that will happen. You will do a little bit differently, as Dr. Andre mentioned earlier, if this were the front teeth. Obviously, you don't want the patient to have a space, right in the front. In that case, you would probably, like to do some more virtual partition effect in there. Okay. The lower right one, pay attention to that also. In just 2 months, it has gotten derotated already. So now, it's easy to just bond a bracket directionally. Directly, and engage the wire, much easier than before, right? So to keep things easy is important. Next slide. Okay, in 5 months, I haven't really gotten much improvement in the overbite. Okay, just because we design, the smile design in a way to have, proper overbite doesn't mean that you're going to get that, especially in the vertical dimension. Like most of the other orthodontic devices, we need a little bit of help, on the vertical dimension. But this patient wasn't willing to give us the help, and she was not very thrilled using the rubber bands. Okay, but other things are going really well. You see that space on the lower left side. At 5 months' time, that is already closed by itself without me doing anything. So that's the beauty of this program, non-sliding mechanics. It happens automatically. And the lower right one still has a little bit of a rotation here, but we have decided to actually move on to SmartWire 2. Obviously, before you do that, check all the bracket positions and check if all the IPRs are done, and leave the SmartWire 1 long enough to fully express. This is 5 months. We have reached that milestone, so we move on to SmartWire 2. The upper, is pretty simple, and there's not much to say about that. Move on to the next slide. And we leave the SmartWire 2 for actually 5 months, before we decide to actually move on for a digital enhancement. We only use digital enhancement for something that we cannot do with the first set of wires. In this case, we need a little bit of help by doing IPR and bring the teeth back more, and utilizing that favorable tooth movement, which is the relative extrusion of the teeth. So that's why we use the DE for this case, after we leave the SmartWire 2 for many months. In this case, I probably didn't have to wait that long. I probably should have done that like, month 7 or 8. This is the DE tooth movement that we requested. Again, as Dr. Andre mentioned, less is more. We left most of the teeth, at the same, places, and only add the IPR, both upper and lower, and request the space closure, of course, and also give a overcorrection in the overbite at 2.5 millimeters, and also, detail the lower right one, which has a little bit of rotation. Next one, and this is the treatment instruction you get from InBrace. It illustrates where the IPRs are, and there's no other work that needs it. That's great. Move on. And so we delivered the SmartWire 2, DE SmartWire 2, at 11th month. For cases like this, that DE only introduce minor, adjustments. You don't need DE SmartWire 1. Okay, we went straight to DE SmartWire 2 at 11 months, and 3 months later, this is what we get. I wish that we could get the bite, closed a little bit more, but the patient again, wasn't willing to give us help by wearing the rubber bands. Actually, she's happy with the way how her teeth turned out. And before she went on, her vacation to Paris, she requested us to remove the braces. We did that and give her both upper and lower fixed retainers, and also Essex overlay retainers on top for her to wear at night. And she came back from Paris, brought me a box of a candle. I didn't know how they're really expensive candles, until my assistant told me about that. I guess she must be really happy with her treatment. And from the Ceph, what you can see is the front teeth, they get pulled back a little bit. We get some relative, favorable extrusion, okay, and to close the bite. That's basically what you get from the panoramic. We didn't have panoramic. Okay, this is the tracing, showing the same treatment effect. Next one. So what we learned from this case, first, take advantage of the favorable tooth movement. After you get more experience with InBrace, you will get very good at identifying these favorable tooth movement and unfavorable tooth movement, and learn how to take advantage of the favorable ones and also counterbalancing the unfavorable ones. When you get to that level, things will become easier. And also temporary space opening when correcting the rotation in the lower left 5, just be aware of that, okay? And also it get closed by itself, okay? And the other thing is the 80% effort rule. What is that? I have, explained. It's, I would want my assistants, to work with 80% of their effort, not to try as hard as they can, because when they do that, they tend to break things. The 80% effort is to reflect, that InBrace is supposed to be easy, okay? If you are unable to do something right there, just wait, give it a little time. As, the case evolves, then it will become easier. Next slide. I'm gonna, this is the toolkit. So InBrace has given out these toolkits developed by our brilliant, Dr. Robert Lee and his team. We put a lot of effort into that, a lot of good information, and they're handy. Please, get familiar with this, and they're going to be really helpful. Okay, I'm going to go to the case 4. This case is a teenager. The chief complaint is there's a big gap, in the front teeth, and the diastema is about 2 millimeters. Dentally is skeletal. Is class 1, both molar and canine. The minimum overbite and overjet. Upper has moderate spacing, and just pay attention that there are spaces not only in the diastema but also distal to the central incisors. Okay, and the lower there's some rotation, there's some spaces to close. Next slide. Skeletally, both upper and lower jaw, they are actually retrusive relative to the cranial bone, so cranial base. That's why the A and B is minus, but the width appraisal is 2 millimeters. So it's basically still considered a class 1 case. panoramic, you can see, everything is pretty good, except that the upper incisors have some mesial crown, tipping. Next one. So this is actually taken, directly from the toolkit. When we're dealing with space closing, you just have to address the tip and torque over corrections. And for the tip, there is as easy as 3, 6, 9. What it means is that for each additional millimeter of space closure, you need to add 3 degrees additional counter tip, to counter the side effect. And also on the bottom, you would have to know that you need to take the original tip into the equation as well, okay, to subtract and add, depending on where the teeth are tipping. Okay, next one. So this is the smile design. So both sides are class 1. Really, the intention is to close, the spaces and get the teeth straight. You notice that, I put a lot of torque, in this case, okay? But I did not put much a counter tip in the smile design. And the reason is because I'm closing the space, not just in the diastema. There are spaces to close distal, to the centrals. So they go the crown tip mesial and tip distal, so they, end up canceling each other out. The net effect is really retracting the teeth and moving teeth lingually, which tend to have the problem of losing torque. That's why in this case I put a lot of labial crown and lingual root torque. Okay, and not only that, when you see the overbite, I left the overbite at edge to edge, even though this case actually started with minimum overbite. This is really, to counter the side effect of relative extrusion, when you retract the teeth and close the spaces. So again, this is the treatment instruction. We know that the lower left 4 need to be directly bonded, and there is a bite interference on the upper right 2, so I probably would need some biturbo over there. No bracket need to be repositioned. That's great. And there's some IPR, in this case, really in the lower, just to solve the two-side discrepancy problem. So fitting appointment, again, this case was fitted both upper and lower at the same time. Again, now if we were to do it, we'll probably do the lower, because there is a expected bite interference, on the upper right 2. Why did I put the upper right 2? I mean, the biturbo instead of just on the upper right 2? I put all 4, incisors. The reason is because I'm trying to use that biturbo as a function to control the overbite, not to allow the teeth to extrude. Okay, and lower left 4, we directly bonded, that bracket. Again, just try to develop, that kind of skill, then it will serve you really, really well, in this type of cases. Okay, go ahead. This is a progress in 2 months. What you notice that the diastema closed more than halfway, and it has not, shown too much mesial crown tipping, which is great. And the upper space is closed, most of the way. And the lower, you see that lower left 4, in 2 months, the rotation is fully taken care of. At this appointment, we have also, taken care of the lower IPR already. So we move on to smart wire 2. On the upper, there are some more spaces to close, so we stayed on smart wire 1. Next, at 4 months, you see the diastema completely closed. I actually had gotten a little bit of a mesial crown tipping, later on, that resolved, by itself. The upper, as you can see, there's still a little bit of a space, here and there. And we kept the smart wire 1 for a little bit longer until the 7th month. Next slide, to switch the upper to smart wire 2. And also you can see the tipping, actually recovered, a little bit. Okay, there's some other, minor spaces to close. So we leave the SmartWire 2, for the next few months. And at 9 months, I believe, next slide. At 9 months, I set this case in for a digital enhancement. Again, there are a lot of things that I have accomplished with just the first set of wires, and I request the DE to accomplish, what I cannot do with the first set of wires. Okay, so this is the DE submission, and this is a setup, the comparison, between the two. As you can see, I design some more extrusion, of the upper incisors and bring the bite a little bit closer. We also added some IPR to close, some of the, I think it's the virtual IPR, virtual parching effect. We're trying to close, all the residual spaces, basically. And also dealing with some minor, changes. So this is the kind of tooth movements I requested. Normalize the upper central, tip, just, a little bit of a correction in there. Add upper 2-to-2 torque over correction. This is really just to maintain the torque that is in there, and add a virtual parching effect and close all residual spaces to tighten things up a little bit, and also give a overbite of 2.5 millimeters, and level the upper teeth a little bit down. As you can see, the two centrals levels down, a little bit. Moving forward. So this is at 30 months. As you can see, the two central incisors, tip, is very nice. The spaces get close, except a little bit between the 3 and 4s on the upper. The patient is happy, requested, debond. So we remove the braces and, give the fixed retainers and also Essex retainers, on top for the patient to wear at night. This is the sequence, the initial, the 2 months, the 4 months, okay. And the 4 months is still with the SmartWire 1, and at 7 months, we change to SmartWire 2 on the upper, okay. At 9 months, I don't have the photo, in there. At 9 months, we submit for digital enhancement, and we got the case, finished at 30 months on a DE, the first DE, SmartWire 2, okay. And this is the lateral ceph. As you can see, the upper incisors, most importantly, the upper incisor torque, got maintained. We closed 5 millimeter space, and we got maintained, and thanks to that torque overcorrection that we put in there. The lower, we actually did lose a little bit of a torque. The lower incisors are very small. It's very easy to get pulled back and lose torque. So more attention should be, paid to the lower incisor torque. This is the panoramic X-ray. As you can see, the upper incisors tip, they actually have improved, from the original, which is great. And what we learned from this case, upper one tipping side effect from diastema closure can be canceled by the spaces distal to the central incisors. Okay, so you have to consider, where the spaces are. Okay, incisor torque overcorrection is necessary for closing minor, more than minor spaces. If it's just 1 to 2 millimeters, you probably don't need to have to worry too much about that. But when you close, moderate, like 5 millimeter spaces, like in this case, you do need to address that. And also use interior bite turbos to prevent bite deepening during space closure. This is, what I used for this case. It turned out to be good. Okay, let's move on to the next case. I have 5 minutes. See if we can finish in 5. All right. This is a 21-year-old actress, and the chief complaint is the two central incisors, are too long. She also looked into Invisalign, but decided that wasn't, for her. Class 1 dentally, basically, it's a minor crowding. The biggest problem is the upper incisors are too far down. Okay, and from the X-ray lateral ceph, basically is a skeletal class 2. Okay, almost like I'm sorry, a skeletal class 2 in the upper incisors are kind of upright, lower incisors are flailing forward. Looks like a little bit of a class 2 div 2 kind of case. Okay, the facially looks good, and the panel is non-contributory. This is the design. Okay, so what we did is that we intruded the upper incisors, a little bit of class 2 on both sides. We intruded the upper incisors and level the upper arch. Okay, we keep the upper 2 to 2 almost level as an overcorrection. And also the biggest overcorrection is the upper incisor labial crown and lingual root torque. Okay, and because we want to give the patient a proper inclination of the teeth. This is the treatment instruction. What you see is that the upper left 3, because of the rotation is not included, bracket is not included in the direct bonding tray. So be prepared again to do direct bonding. Upper left 1 and 2, there's some collision, so may need some biturbo. This is the fitting appointment. This one we did the lower arch, okay, because of the body interference expected, on the upper if we were to do both. So there's, not a whole lot to say about the fitting appointment. Engage the SmartWire 1. There's no IPR in this case. Next one. So what happened in 6 months? You can see the lower teeth aligned and leveled. It actually opened up a little, bite already, making the biturbo that we thought we may need unnecessary. Again, keep things simple. Okay. In the upper arch, I want you to pay attention to the upper 3s. Next slide. The upper left 3. What we did is, direct bonding. Again, it is a skill that I hope people, the providers, you can develop. It's going to serve you really well. It's not as hard as you imagined. Okay. What I want you to pay attention is that this wire was not fully engaged because it's hard. You have to jam it, and you're running the risk of breaking, wire over here. So what we did is we partially engaged, the wire and put some soft flow, over it. Again, this is the place where that 80% effort rule, applies. So what happens in 2.5 months? You can see the leveling of the upper incisors, they have improved. The torque has improved. Okay, and the upper left 3, you see the rotation, even with partial derotation, partial engagement, the rotation, is taken care of. Okay, and now it's so much easier to just engage it. And again, this is that 80% effort rule. Don't try to jam it. At the first appointment, wait until case evolves. Now it's so much easier. This is 3.5 months. As you can see, the leveling, the alignment, and also the overbite have all improved a lot. At this appointment, we switch both upper and lower to SmartWire 2. Next is the 5 months. You can see it's pretty much all resolved. Leveling, proper inclination of the upper incisors, and the alignment. The patient is actually already pretty happy. So let's take a look at this leveling of the upper incisors. You would expect probably that we intruded the upper and central incisors. Is that really the case? Let's look at the smile pictures. What you see from the comparison between the initial and the 5 months of the upper central incisors. I mean, the incisors lightly touching the lower lip. The incisor show is pretty much the same as the initial. So the upper central incisors have not really been intruded, if anything at all. But pay attention to the laterals and the canines. They are now touching down, especially on the right side, the lower lip. So what happened is in here is actually not so much the intrusion of the upper central incisors. It's really the extrusion of the adjacent teeth. This confirms the notion that orthodontic forces are mostly basically extrusive in nature. This is something we already know. Okay, and also you can see the improvement on the inclination of the central incisors. At this point of time, there is still some minor spaces in between teeth that I want to close. So we sent in for a DE. The DE type of tooth movement request is maintain the upper to the two palatal root torque over correction. Okay, and what we actually want to achieve a little bit more, and the level of the upper anterior teeth, again trying to keep the deep bite, the overbite, where it is now, and also add some virtual partition effect to address some of the residual spaces. This is 10 months. As you can see, we have pretty much achieved all the treatment goals, level, line, and proper inclination of the teeth. The next slide actually shows the improvement of the upper central incisor torque. So with InBrace, we can, torque the teeth. It's just that, sometimes it takes some extra overcorrections. Okay. So what we've learned from this case, 80% effort rule, I want to punt that, because it's important. Okay. When you force things, then you tend to break things, and just give the wires some time to develop. Level and the bite opening in this case is achieved by not so much actually the upper incisor intrusion, but mostly adjacent teeth extrusion and lower reverse curve speed. That's how we actually open the bite. Okay, the overcorrection is necessary for the torque. So that's basically the takeaway from this case. That's about it. So thank you for everybody's attention. Any questions?
Okay, Dr. Tong, thank you for sharing those amazing cases. And I think we're running a little bit short on time, so I'm gonna go ahead and wrap it up here, because we will have a study club on July 26th at 5 p.m. Pacific, 8 p.m. Eastern. Please, make sure you sign up for it either on the in-group on Facebook, or check your email, or work with your TIS. And in that study club, we're going to cover a lot of these same topics, just in a more intimate virtual setting where we can engage much more with each other. Also, there'll be a survey going out to all of you, so please take it so that we can learn from your feedback on how to improve our educational content. And lastly, of course, the best thing you can do for us is refer a friend if you think this is good stuff that we're covering. Reach out to InBrace provider to have them join in on these learnings, or talk to a friend to have them join our InBrace Nation. So with that, thank you for your time, and we'll see you at the study club. Thank you, everyone. Thank you, Dr. Tong. Thank you, Dr.
Thank you.
Thank you.
Thank you, Dr. Fan.
Thank you.
Bye-bye.
Have a good day.